Welcome back to the Ninja Nerd Podcast. Today we're talking about blood transfusion. We've got 7 cases to cover, a lot of information to be had. And I guess I'm wondering, Zach, when you do a blood transfusion, what are some big things you're looking out for?
Yeah, when you give blood products, there's a lot of different products to give. So you have to know what they are. Really, what are they designed for? So we'll talk today about the utilization of packed red blood cells. We'll talk about platelet transfusions. We'll talk about FFP versus cryo versus PCC, when those things should be particularly utilized. And on top of that, how do we know when they're being effective? Is there a certain lab that we should be monitoring for? Is there a certain clinical feature that we should be assessing for? And then lastly, we shouldn't just be giving these blood products just willy-nilly. They always come with potential risks and complications. And so we should be aware of what those complications are and then how we can mitigate that.
So case 1, we have a 55-year-old male presents with fatigue, lightheadedness, and shortness of breath on exertion. The HPI, the patient reports progressive fatigue over the last 2 weeks. He also describes dizziness when standing and increasing difficulty walking short distances without feeling out of breath. He denies any chest pain, palpitations, or significant bleeding, but mentions a history of chronic kidney disease. For our exam, his vitals, blood pressure is 105/65, heart rate is 98, respirations are 18, and his temp is 36.7 Celsius. His skin appears pale with no petechiae or purpura. Neurologic, he is alert and oriented. There's no focal deficits. We do some lab work. We get the following back. Hemoglobin of 6.8, hematocrit 20%, reticulocyte index less than 2%, MCV is 88, ferritin is normal, and iron studies are normal. So some questions for you, Zach, about this patient. Should this patient receive a transfusion, and if so, why?
Yeah, so I think they should receive a transfusion, and what they should specifically receive is a packed red blood cell transfusion. The reason why is, with this patient, they have a hemoglobin of 6.8. Any hemoglobin less than 7 is kind of a general number or threshold by which we should trigger a transfusion, especially a packed red blood cells. There are certain indications as to when we would have those hemoglobin thresholds potentially just a little bit higher. This is extremely controversial out there in the cardiac world and in other areas, but oftentimes, if a patient has a pre-existing history of coronary artery disease, CHF, they're getting a cardiac surgery of some sort, and some even say if they have an acute coronary syndrome, you'll aim for a hemoglobin. If their hemoglobin is less than 8, you should transfuse them to get them above 8. Otherwise, this patient doesn't have any underlying history of CAD, CHF, cardiac history, evidence that suggests an acute coronary syndrome. So therefore, I'm not going to trigger them to get above 8. I just need to get right above 7. And so that's what I would do, is I would try to really push this patient to get right just above 7 to meet that hemoglobin threshold.
How do we determine the amount of packed red blood cells to give to this patient?
So there's a kind of I'd say a rule of thumb, and that is usually that 1 unit of packed red blood cells is at least going to increase the hemoglobin by about 1 gram per DL. So in this particular patient, she has a hemoglobin of 6.8. So 6.8, I'm going to give 1 unit. If I give 1 unit, it'll push that hemoglobin from 6.8 to 7.8, get me right above that normal level.
We are talking about a male here, not a female.
Oh, sorry. Okay, my bad.
It's been a while.
I know. I'm sorry.
You've done well recently.
Dang it.
All right. He broke his streak.
I'm sorry, guys. I'm sorry.
If this patient has a history of frequent transfusions or is immunocompromised, is there anything special we should do to the packed red blood cells before transfusing? And then why? Yeah,
that's a really good question. The reason why I think that's important to understand is that this always comes with the concept of when you give packed red blood cells or any kind of blood product itself, it comes with risks. One of the big things is in patients who have a history of frequent transfusions, they're at high risk of potentially what's called febrile non-hemolytic transfusion reactions. And they're also at risk of what's called alloimmunization. If you've had frequent transfusions, you can potentially have the recipient, the person who's receiving those blood products, they've possibly developed alloantibodies against these red blood cell antigens. And so if they get exposed to it again, they can trigger these types of hemolytic reactions, or they could trigger febrile reactions. So that's one really big thing that I would want to watch out for. Also, immunocompromised patients, really, really high risk for CMV infections. And so because you actually give packed red blood cells, most patients, you probably don't know this, but there probably is a little bit of CMV, the cytomegalovirus, in those cells. If you have a normal immune system, you should be able to fight that off. If you're immunocompromised, like a patient who has AIDS, they have a bone marrow transplant of recent sorts, or they have a malignancy of sorts that puts them at a little bit high risk and immunocompromised, you got to be really careful. So they do have a higher risk of CMV infection. So the reason why in this patient, I would really consider something called leukoreduction. In other words, what we do is we take the actual packed red blood cells and we get rid of a lot of the white cells. So normally when we give packed red blood cells, it does contain red blood cells and a little bit of plasma, but sometimes there'll be white blood cells in there. So if I gave this patient who is immunocompromised, who has had frequent transfusions, they're at high risk and they can generate an immune reaction. So I want to get rid of those white blood cells and reduce that risk of them having CMV infections, as well as reduce the risk of them developing kind of an immune reaction to that.
Let me run another scenario by you. Let's say this patient has a history of a recent bone marrow transplant, you had mentioned it briefly, and suddenly develops a rash, elevated LFTs, and diarrhea. What is the concern here, and how could this have been prevented?
This is another one. So anytime you give blood products, you run the risk of, again, there being not just white blood cells, but you also run the risk of there being a very specific type of white blood cell, and that's T cells. And so T cells, when actually introduced into a recipient, sometimes those T cells can trigger an immune reaction, and it can literally cause a very fatal condition called transfusion-associated graft-versus-host disease. And so if a patient receives these packed red blood cells that contain some of the T cells in it, they can start to attack the recipient's own tissues. This can lead to, again, these features here that you would see. Pancytopenia is a really, really big one that we would see. Elevated LFTs, we would also potentially see rash, some GI symptoms, but oftentimes these patients, most of them die. And so that's why it's a very, very serious thing. And so in order to prevent this from happening, the best thing that you can do is actually irradiate the blood product. So when we talked about leukoreduction, most hospitals or institutions, any kind of blood product, usually leukoreduce it. You get rid of those white blood cells. For irradiation, we really only do that for patients who are super immunocompromised. So they have let's say that they have a very high risk of this. And so what we would say is they have a bone marrow transplant, like you said, or just a recent bone marrow transplant. They have a hematologic malignancy like lymphoma, leukemia. Those are really, really big ones where I would probably say, okay, or they have a congenital immunodeficiency. In those scenarios, I have to irradiate the blood because they're super high risk and they can get this condition. So irradiation of blood product is really good for preventing graft versus host disease. And leukoreduction is good as preventing what's called febrile non-hemolytic reactions, alloimmunization, and CMV infections. And so that's what I would consider for these scenarios.
So missing this step, that could be pretty detrimental for a patient.
Fatal, yeah.
All right, well then there's case one. Let's move on to case two now. And we're going to be talking about the next patient. We have a 45-year-old female, remember, female, presents with easy bruising and prolonged bleeding from a small cut on her hand. The patient reports noticing frequent bruises on her arms and legs over the past week without significant trauma. She also describes prolonged bleeding from minor cuts. She denies fever, weight loss, or recent infection. She has a history of systemic lupus erythematosus and is currently on prednisone. For her exam, we do some vitals. Blood pressure is 130/75. Heart rate is 85. Respirations are 18. Temp is 36.8 Celsius. On her skin, we notice multiple ecchymosis over her arms and legs, but there is no petechiae present. For lab findings, we get the following: a platelet count of 15,000, PT-INR normal, PTT normal. Those platelets are in the gutter.
Yeah, they're really in the pooper. That's not a good one.
That's bad.
Yeah. Lowest I've ever seen is like 9,000.
Wow.
Yeah, but this is pretty bad.
Yeah, that's rough. I mean, what's normal? Like that's upwards of like
at least above 150,000 at the minimum. Yeah, so this one's really low.
No wonder you might flick her and then she'll start bruising everywhere.
Seriously.
All right, so should this patient, I think we already answered this, should this patient receive a platelet transfusion and why?
Yeah, so this one definitely should. The reason why for this one is because we have thresholds, right? So again, every blood product comes with risks. In this potential scenario, this patient warrants it because they are bleeding. And so when a patient is bleeding, we trigger that threshold at less than 50,000. So you would think, oh, well, you want to push it above 150,000. But the same thing, like in a patient who has anemia, they were 6.8. We don't push them up to 13 or 12.
Sure.
So in the same thing, we just push them right above 7. In this scenario, we just want to push just above 50,000. So that's what I would do here for this patient. I would push above 50,000. If the patient was not bleeding or completely asymptomatic, no issues whatsoever, happened to get a CBC and found that they have a platelet less than 10,000, then I would transfuse. But if this patient was completely asymptomatic, I wouldn't transfuse.
Wow.
And so that's the kind of the big thing here. If they're completely asymptomatic, no issues, don't give them. That's why everything comes with risks. So if they had less than 10,000, I would transfuse if they were completely asymptomatic. But if they were bleeding, they were getting ready to have some kind of procedure done, as long as it has nothing to do with the brain, I go for greater than 50 as that goal.
Okay.
The only time where I'll push a little bit higher to greater than 100,000 as kind of the trigger to go above that is if they're getting a neurosurgical intervention or they have a CNS bleed. This is somewhat controversial in the neurocritical care world, but I'd say for the most part, greater than 100,000 for any kind of neurosurgical intervention at least. So for this patient, I would just push right above 50,000. They're not getting a neurosurgical intervention of any sort. They don't have any CNS bleeding. And again, if they were asymptomatic, I would even wait a little bit longer. But for this patient, I'd give them at least some platelets.
All right. How do we determine the amount of platelets to give to this patient?
That one's a tough one because platelets are a little funky. It's not like hemoglobin. So one unit can increase it by anywhere from like, some will say 20, some can actually get up to 60,000.
Oh, wow.
So it's kind of random. I would start with one platelet transfusion at first and then see where I can get from there. But that'd be kind of the way I would go. And sometimes we even use other ways of monitoring the effectiveness. So sometimes we'll use things like thromboelastography to really assess this, but you can just repeat a CBC and see if the platelets went up.
So for this patient, though, starting at 1 unit is good, and then say, all right, where are we at?
Yep.
And if you need to get to that threshold of 50, you might have to give a little bit more.
Exactly.
All right.
Yep.
When should platelet transfusions be avoided, and why?
There is certain scenarios where if it's an immune reaction, you should definitely be careful. And the reason why is, for example, if a patient has TTP, they form clots, right? So they actually increase the risk of clots by consuming platelets, and so they develop thrombocytopenia. Same thing in another one called heparin-induced thrombocytopenia. So if they got heparin exposure and they developed clots because of that, they consume their platelets and develop clots. If I give them a platelet transfusion, all I'm going to do is just fuel the fire and continue to consume the platelets to make clots.
And just to clarify, TTP is?
It's called thrombotic thrombocytopenic purpura. So in those conditions, I'd say TTP, I'd say the big one, HIT or HIT. Those would be the ones that I would just do not give them platelet transfusions. You run the risk of propagating more clots and then just consuming the platelets.
Good to know.
So no benefit there, yeah.
All right. Why should platelets be washed in patients with IgA deficiency or recurrent allergic reactions to transfusions? What could happen if they weren't washed, and how would you treat that acutely?
So whenever a patient is receiving a product, let's say it's packed red cells, it's platelets, or even a plasma product, there's proteins in those products. And those proteins do run the risk of potentially being immunogenic. And so one of the big things is in patients who have IgA deficiency, which is kind of interesting here, they actually have a weird condition where they actually make anti-IgA antibodies. And so if you give a patient you give them a platelet transfusion, in that platelet transfusion is plasma, which contains different types of IgA antibodies. If they get exposed to the IgA antibodies, their plasma cells will actually generate these anti-IgA antibodies, and they'll actually bind with the IgE antibodies on mast cells and trigger a massive degranulation. Another thing is if a patient has a protein in their plasma that maybe they just have a weird reaction to, that can bind onto IgE antibodies on the mast cells and just cause massive degranulation, huge histamine response. So that histamine response, what you don't want to watch out for is if it's a minor allergic reaction, they may just get like some urticaria, right? So they may develop some like hives and stuff like that. They could develop pruritus, so some itching, maybe some mild respiratory kind of symptoms. Maybe they get like some angioedema, like some swelling of the face and the lips. Sometimes it can even involve the larynx. That's where it gets kind of scary. But the worst case scenario is in a patient who has IgA deficiency, if you give them that product and it does have IgA antibodies, it can cause enough histamine response to put a patient into anaphylactic shock. So they can develop severe hypotension, they can develop wheezing, stridor, dyspnea, their larynx can close off, and they could have a cardiac collapse. And so you really want to be careful for those scenarios. So we wash these to get rid of those proteins, to remove those IgA antibodies, to remove those plasma proteins that can cause these immunogenic reactions so they don't develop an anaphylactic reaction. If they do develop one, we treat that acutely with steroids and antihistamines and epinephrine if it's enough that's causing respiratory compromise and hypotension. But to best prevent that from happening, if they know they have an IgA deficiency or they had a previous reaction, is to wash that product off, to get rid of those proteins, to get rid of those IgA antibodies.
I'm glad you just mentioned that, because in my head I'm thinking, what if they don't know that they have IgA deficiency or it hasn't been documented anywhere? It's just like, you almost have to say, well, you might have a reaction.
Yeah, and so when that happens, you obviously when we put our orders in, so for example, if I give a patient a blood transfusion, usually in every kind of order set, you put in a alternative drugs that could be available to the nurses. So let's say that I put in an order for them to get a platelet transfusion. I also put in orders for steroids, antihistamines, and epinephrine.
So you're almost covering yourself.
Yeah, just in case something happens.
Right,
yeah.
as a backup plan.
Yeah, and so then from there, you have those orders ready. So if they start to develop any symptoms, there's particular order sets that are available for the nurse and the team to say, hey, they're developing these symptoms. I'm going to go ahead and grab that medication.
Right,
and
you don't have to wait on it. It's already ready to go.
Yep.
Do it.
So that's oftentimes what we'll do. But again, it's always good to know, oh, you have a history of this. We should wash that blood product. If not, unfortunately, you may find out, treat that, and then hopefully the next time prevent that by washing the blood product.
Sure. Okay. All right. Well, then that was case 2. Let's move on to case 3. We have a 60-year-old male presents with epistaxis and generalized bruising. The patient reports frequent nosebleeds over the past week and large bruises appearing after minor bumps. He has a history of liver cirrhosis secondary to alcohol use, but denies recent alcohol consumption. For his exam, vitals are BP 125/80, heart rate is 88, respiration 16, temp is 37.2 Celsius. For the skin, there is large ecchymoses on the arms and legs. For our lab findings, we get a PT-INR of 2.8, PTT is elevated, and a platelet count of 120,000. So Zach, as we've been asking, should this patient receive fresh frozen plasma, and if so, why?
Yeah, this one definitely should get this. And the reason why is that for fresh frozen plasma, it's pretty much our plasma. It's really all of our plasma, so it contains all the clotting factors that you could ever imagine. So all clotting factors are contained in the plasma. And then on top of that, we even have proteins like fibrinogen, von Willebrand factor, all of those. So this is a great thing that you basically, if a patient has a coagulopathy in this case, and so this is due to cirrhosis. Cirrhosis, you lose the ability to make most of your clotting proteins. And there's another disease called DIC where you consume a lot of those clotting proteins. So in those diseases, what happens is you consume or you don't make clotting proteins. And so what happens is you just need to replenish that. And so especially if the INR is greater than 1.6, we may aim to get that less than 1.6. And so that's when I would give FFP to see if that's actually going to help to bring that INR from 2.8 maybe down to less than 1.6, especially since this patient is having some evidence of bleeding. That would definitely push me to get a little bit more aggressive.
Being that the PT-INR is at 2.8, just out of curiosity, what other things can go wrong if that doesn't get fixed?
The worst case scenario is that I would be concerned about is an intracranial hemorrhage.
Okay.
So that's definitely devastating enough that it can be debilitating to the patient. So I've seen patients who have had cirrhosis who develop coagulopathies due to an abnormal, PT-INR. But on top of that, they also have concomitant thrombocytopenia. And so that would be my big concern is if I don't actually take care of this, that they could develop further bleeding. GI bleeding is a really, really scary one. Okay. And then especially with having a history of cirrhosis, there is super high risk for esophageal varices or other types of GI bleeds from the stomach. But,
True.
The biggest thing that I'd be concerned of is enough bleeding to the point where it can actually cause coagulopathy and bleeding in the brain.
How do we determine if the FFP was effective in this patient? Is there something specific to monitor?
Yeah, so ideally INR, but also lack of bleeding or continuous bleeding would be the goal, right?
Okay.
So I think it's a combination of both. I would want to make sure that the patient doesn't have any more frequent nosebleeds. They're not having as much of the bruising that's going on and the large ecchymoses. So what I would do is I would start off with maybe a unit of FFP, see if I can bring that INR down. That's the easiest way of doing it is I'm going to try to get that INR to less than 1.6. That would be my ideal goal, but I also want to aim for stopping the bleeding too. So that would kind of be like the way that I would determine if it was effective is was I able to get the INR to at least less than 1.6. Problem is in cirrhotic patients, you may never ever be able to get them to that point. It's a little bit more difficult. And so that's not always the perfect scenario, but I would say that I would try to get that PT-INR to get close to 1.6 or less, but aim for this patient, especially with underlying history of cirrhosis, I would really try to do my best to get it to where they're not bleeding. A better test for cirrhotics tends to be this test out there that's being utilized called a thromboelastography. It's a way better at determining if a patient's true physiological activity of their clot is working. So I would actually defer. We don't really talk about this much for USMLE Step 2CK, but this is more of a clinical pearl. Okay. Thromboelastography or TEGs are much, much better in patients who have cirrhosis and you're trying to improve a coagulopathy for them.
Besides just FFP, couldn't you also give the patient like vitamin K?
You could, yeah, absolutely. But I'd say that the big thing for patients who have the need for vitamin K is it's usually due to like a warfarin problem. So warfarin is a vitamin K antagonist, and so it'll deplete the vitamin K dependent coagulation factors. You can give vitamin K in cirrhotics. You could actually try it; wouldn't hurt them. But I'd say it's more indicated to give like vitamin K and FFP in a patient who has more likely a warfarin coagulopathy than a cirrhotic process.
Gotcha,
but it still doesn't hurt. It wouldn't be a bad thing to do.
But just in this situation, based upon the patient's underlying history, we have a better idea of what we're doing.
And vitamin K will work if a liver is kind of susceptible to allowing it to work. So vitamin K depends upon a functional liver to really make enough of these proteins.
And our friend right here doesn't have it.
Yeah, and that's why it's not going to hurt to try it, but I just don't know how effective it would actually be. But it's not going to hurt to try it.
All right. If a patient develops a high fever and chills 2 hours after an FFP transfusion, what is the cause? How do we treat it? And how do you prevent that from happening?
That's a good question. So the two big ones that I would be watching out for is an acute hemolytic reaction. And then the other one is a febrile non-hemolytic transfusion reaction. The biggest way to tell the difference between these two is if there's evidence of hemolysis. So a positive Coombs test, I would actually order a Coombs test. I'd order an LDH. I'd order a haptoglobin, an indirect bili. All the things that we've talked about in prior discussions with anemia, especially the hemolytic anemias. So if the Coombs test came back negative, if the LDH was normal, if the haptoglobin was normal, if the indirect bili wasn't significant, and they just had a fever, I'd probably be more likely to suggest it's that. Also, we see this in younger patients too. So our patient was 45. I'd say you can see it in that age range.
60.
Was I looking at the wrong one? Oh, yep, 60.
Yeah.
So definitely it is possible to get a acute hemolytic reaction or non-febrile hemolytic reaction. The best thing I would do is say, let's see if they have any evidence of hemolysis. And also usually there would be other multi-system organ involvement. So AKI, hypotension, I don't really see any of that in this patient. So I would be willing to bet that it's more likely the febrile non-hemolytic transfusion reaction that's caused this. That's usually due to the cytokines. Whenever you give them this product, there may be a little bit of white blood cells in there and they can release cytokines and cause this fever. But confirm first that there's no hemolysis. If there's no hemolysis, you can probably say that. And the way I would treat that is stop the transfusion for a bit, give them acetaminophen to actually help to bring the fever down. And then if we can in the future, it's best to actually try to prevent those white blood cells from even getting there. So leukoreduce it. So I would do the same thing that we talked about in the prior scenarios where if a patient has a history of frequent transfusions, they're immunocompromised of sorts, I would probably go ahead and leukoreduce. And most hospitals, they do leukoreduce all their blood products, but that's what I would do here.
Why is FFP preferred over other plasma derivatives in a massive transfusion protocol?
So massive transfusion it's a dumb definition out there, but they say it's whenever you give more than 10 units over a 24-hour period. And I don't think we're like, so when you think about a massive transfusion, you have to kind of interpret the future. So that's why I don't really like that definition of it. It's kind of like a massive hemoptysis, like the amount of volume you have to, cough up to truly.
That is kind of weird to think about that.
Yeah. So I think the best way of determining a massive transfusion is if a patient is truly exsanguinating and losing blood and you're having to push blood product into them really, really fast. If I was a provider, I'd probably say anytime I have to hook a Belmont up to a patient to push blood product into them, I'm activating a massive transfusion. So with massive transfusion protocols, you have to replace whole blood. So if you're losing whole blood, you give them back whole blood. And that is, I give them 1 unit of packed red blood cells. For every 1 unit of that, I give them 1 unit of platelets. And then for every 1 unit of platelets, I would also give 1 unit of FFP.
Wow.
So that's oftentimes the way that we would give that. The other benefit is if a patient is hemorrhaging, it's going to give you volume. So FFP is about 300 mLs a bag. So whenever usually you activate a massive transfusion protocol, they'll come in like this big, I'm not even kidding, like a cooler. And usually in that, you'll have multiple packs of red cells, platelets, FFP. And sometimes what I would do is we'll push this into the patient as quickly as we can to really improve that blood pressure, their overall organ function, and then get them to a OR to do source control. So the best reason for FFP is because it's a part of that 1:1:1 ratio. Is you give them 1 unit packed red cells, 1 unit of platelets, 1 unit of FFP. It's going to replace all the coagulation factors. So if I have a patient bleeding and they're bleeding whole blood, they're losing all their coagulation factors, I'll give them all that back.
Yeah.
If they're losing platelets, I'm going to give them that back. And if they're losing blood, I'm giving that back. So I'm basically replacing all the things that they're losing to hopefully get them stable enough to survive this, get them to the OR to have undergoing source control. So that would be the reason why. And then also gives you a little bit of volume as compared to things like cryoprecipitate, which doesn't have as much of those clotting factors. And then prothrombin complex concentrate, or PCC, that one only has some of those clotting factors. And so FFP would give you all of them, which is the best case scenario here.
All right. Well, there was case 3. Let's move on into case 4. We have a 70-year-old male presents with hematemesis and dizziness. The HPI, the patient has been on warfarin for AFib and recently noted black tarry stools followed by hematemesis. He denies chest pain or abdominal pain but describes feeling lightheaded. For the patient's exam, vitals, BP is 95/65, heart rate 112, respiration is 20, and his temp is 36.8 Celsius. His abdomen is non-tender. We do some lab work, we get back the following: PT-INR of 4.5, holy God. Platelet count, because I thought 2.8 was bad in our other patient.
Yeah.
Again, this is, like, what's the highest you've seen?
I want to say like 7.
What?
Yeah.
Oh.
I've had like providers who've said that they've seen greater than 10, but I haven't seen it like, that high, like where I've seen above 10, but
sure.
7 I think is the highest one I've ever seen.
That's insane.
Yeah.
So again, PT-INR 4.5 and his platelet count is 190,000.
Yeah, it's pretty good. Yeah.
So on the discussion of PCC, you had just briefly mentioned it in the last case.
Yeah.
Should this patient receive PCC, and if so, why? If this is due to warfarin coagulopathy, what should we add and why?
So I think this is a great one, and it kind of follows up with what you said, which is, do we ever give vitamin K in that last scenario? And I think this is the time where I would give vitamin K. So I give 10 milligrams IV vitamin K. And then the other thing I would do is I would definitely give them PCC. So PCC is prothrombin complex concentrate. Also sometimes call it Kcentra. Some will call it 4-factor PCC. There's a lot of different names out there for it. But I like 4-factor PCC, and the reason why is it tells you what's in it. It's factor 2, 7, 9, 10. It does contain a little bit of other things in it, like heparin, funny enough, and then a little bit of like protein C and S and stuff like that. But these are the biggest components, is the 2, 7, 9, 10. And so those are clotting factors, which are very, very affected by warfarin. So warfarin actually inhibits the production of vitamin K dependent coagulation factors, 2, 7, 9, 10. So if I give them PCC, I'm replacing what warfarin's inhibiting. And if I give them vitamin K, I'll help the liver to continue to keep producing these proteins after I replenish them with the PCC. So that's the reason why I would definitely do this. And adding to this, the reason why I would do this is twofold. One is because they're on warfarin and they're having symptoms. They're bleeding. Second one is their INR is super therapeutic, right? So it's going to kind of fix both of those. So I would give them 10 milligrams of IV vitamin K. I would give them Kcentra or 4-factor PCC. And then I would also kind of keep a close eye on if they're actually having an improvement in their bleeding. And then I would keep an eye on their PT-INR as well.
Like previous patients, when we're monitoring the administration of these agents, are we looking at the PT-INR?
Yeah.
Or really the INR we're looking at here?
Yeah. So I would keep a close eye on the INR. My goal is if this patient does not have a mechanical valve of sorts, which I don't see mentioned,
he does
then
not.
I won't be pushing super, super high. So I'll try to get them down. For right now, I'd actually like to get them to like maybe less than 2 for now. And then after a little bit of time and after they have a stabilization of their underlying bleeding, I'll restart the warfarin. But for right now, my goal is I want to get them kind of on the close to normal range. I don't want to go too low because I don't want them to be high risk of developing a clot in the atria. But I'm definitely going to try and get them kind of closer to normal, give them some time. Once I get that INR closer, I'd say like 1.6, 2, somewhere around that range, and their bleeding is stopped. And if they continue to bleed, then I'll push down lower. I'll go to like 1.5 or like, less than 1.6 at least. Once they stop bleeding, I'll then determine, is it a right time to reinitiate their warfarin? And that is always such a difficult thing to do as a clinician, is to determine when a patient should go back on anticoagulation, especially if they developed a bleed. Usually intracranial bleeding is a really, really hard one to determine. For this patient having AFib, they're at high risk of stroke.
Yeah.
So for them, I would really try to get them back on their warfarin as soon as I can, but I just have to get resolution of the underlying problem, which is their coagulopathy and their bleeding. So I push that INR down, probably, to be safe, I'd push it down close to 1.6, give them some time, see if their bleeding resolves. If it does, restart their warfarin.
Real quick, just for the sake of argument, let's just say he does have a mechanical heart valve. What would you then want the INR to be?
Ooh, that's a tough one because if that valve clots, you're in big trouble.
Yeah.
So usually in those patients, we push pretty high. We actually like to get, sometimes we like to get their INR upwards of like 2.5 to 3.5. And so I would have a much stronger desire to reinitiate warfarin.
Yeah.
There is other agents that we could give in the meantime. So oftentimes in patients who are in the hospital, warfarin's, it's a little bit tougher, right? So I'd like to give IV medication. So if I really need to anticoagulate a patient in the hospital, the best agent to kind of give, because it comes with lower risk of bleeding, is heparin. So to bridge them, I would probably start heparin and just keep a close eye. Plus, I could have a very close monitoring of their PTT or their anti-XA level. And then if they start to develop bleeding, I can reverse it with protamine. It's a little bit harder to do that with warfarin. And so I would probably, if I really needed to reinitiate this, I'd say, I don't really want to. It's not going to be great enough of a drug, especially for mechanical heart valves, but I may consider something like that.
And that's what they say more so. The bridging inpatient is heparin, and then as they start moving outpatient, it's warfarin.
Yeah. And it's always tough. When patients bleed, it is such a challenging thing to determine what do I do with reinitiating anticoagulation. For right now, what I would say is in this patient, no anticoagulation, reverse the underlying warfarin coagulopathy, get that INR down. If you can get it close to 1.6, great. The decision to reinitiate anticoagulation is a really challenging one. Yeah. And that comes with a lot of risks. And so that's a little bit more of a challenging, and I think a clinician and patient by patient basis that you'll get as you become more of a Zentensivist or, experienced clinician, I'd say.
Sure. Why is PCC preferred over FFP in anticoagulation reversal?
So the reason why is because I'd say two reasons, or maybe three, but one, smaller volume. Second one is it's really, really rapid onset. And then the third one is it doesn't require thawing. And you're probably like, so fresh frozen plasma.
Sure.
So it's frozen. So it takes a little bit of time for it to kind of thaw out. It has a slower onset and it comes with more volume. And it replaces a lot more coagulation factors, which isn't a problem, but it's best to give the thing that's going to have rapid onset. It doesn't need to be thawed, and it's going to be a smaller volume to a lot of these patients. And so that's what I would go for in this scenario, is that it's rapid onset. It's going to provide a very quick action. You don't have to thaw it, and you can use it as soon as possible. You don't have to wait 30 minutes for it to thaw out or something.
Oh, wow. Yeah.
And then you can give that. And I think that's the best scenario for this one.
I didn't even think of that. It's true. It's fresh frozen plasma.
Yeah, exactly.
You got to thaw it out.
And there's a lot of other anticoagulant reversals, and we'll probably talk about that at other times, but PCC is really good for warfarin. It can even use it in other scenarios like factor 10A inhibitors. But there is another drug out there besides PCC, which we use for factor 10A inhibitors like apixaban and rivaroxaban. And usually for those, we can give another one called andexanet alpha. It's just expensive as hell, so we try to stay away from it. And I think that there was no true differences in overall response between andexanet alpha and prothrombin complex concentrate.
Okay. Well, that was case 4. Let's move on to case 5.
Let's do it.
We're moving. We have a 40-year-old male presents with persistent bleeding from IV sites and worsening bruising. The patient was admitted to the ICU 3 days ago for sepsis-induced disseminated intravascular coagulation, DIC. He has received multiple transfusions, including packed cells, platelets, fresh frozen plasma, but continues to have active bleeding from IV sites and new ecchymosis on his arms and legs. Lab work from this monitoring showed worsening coagulation abnormalities, and fibrinogen levels have progressively declined. For his exam, we have vitals. BP is 100/60, heart rate is 120, respirations is 22, and his temp is 38.2. So those are a little wacky there, those vitals. Mm-hmm. Skin, it appears numerous ecchymoses on the arms and legs, oozing from the IV sites. His abdomen is non-tender, and for his respiratory exam, it is tachypnic, but clear breath sounds. We do some lab findings. We get a platelet count of 40,000. Now, previously, it was 60,000 when he was first admitted. PT-INR 2.5, PTT is elevated, fibrinogen is 80, and D-dimer is elevated. So some questions for you, Zach. Should this patient receive cryoprecipitate, and if so, why?
Yep, they definitely should.
Everyone is going to be, let me tell you why.
Yep. So this one definitely needs cryoprecipitate. So they had the massive transfusion protocol, right? So that's hopefully the 1-to-1-to-1 ratio to prevent coagulopathies, replace appropriate plasma and platelets and red cells, and not cause these dilutional coagulopathies. But in patients who develop what's called hypofibrinogenemia, which we can see in DIC, you can see in massive transfusion protocols, and you can also see this in postpartum hemorrhage. For some reason, you just chew up your fibrinogen level. And these patients, cryoprecipitate is really one of the best things. So basically, okay, here's how this happens. You take fresh frozen plasma, right? And you want to make PCC. All you do is you fractionate it out. So you get rid of certain proteins. You get rid of the fibrinogen, you get rid of von Willebrand factor, and you get rid of a lot of the proteins, and you're only left with 2, 7, 9, 10. When you make cryo, you just unthaw it. And when you unthaw it, what happens is it actually can cause some of the proteins to precipitate out of solution. That's fibrinogen, von Willebrand factor, factor 8, and factor 13. That's the cryo. So it's the part that precipitates out of solution. You just take that. And it's really a super concentrate. So you take multiple fresh frozen plasma bags, let them kind of precipitate out of solution, take that and put that into one bag, and you get cryoprecipitate. So it's a super concentrated source of fibrinogen, von Willebrand factor, and factor 8 and 13. So you can see why this would be way better than fresh frozen plasma, because it's super, super concentrated amount of fibrinogen.
I almost would think it's a little bit more of a disadvantage though, because you're having to use so much of it to get it boiled down to this one unit.
Yeah, you think, right? But like the benefit of this is that you get a really good source of I'd say the best replacement of a very like, and so, you know, everything is always good whenever you have like lots of coagulation proteins. It's good. But the problem is that maybe you need a little bit more of one than you do of the other.
Okay.
And so not causing that imbalance in these coagulation proteins, I think, is the best thing. And if your patient has a fibrinogen level that's less than 100, some sources even say less than 150, depending upon what you're looking at, you should probably replace the fibrinogen. And the best way to replace it is going to be cryoprecipitate, because it's way more concentrated amounts of fibrinogen as compared to the FFP.
It's just much more indicated in this scenario.
Exactly. So that's what I would do if a patient has hypofibrinogenemia from DIC, massive transfusion, or postpartum hemorrhage. I'd go ahead and I'd chuck a couple. Usually one dose is weird. It's like 10 pooled units of cryo. So it's a lot. But generally with cryoprecipitate, I'd give them a dose of cryo and see if I can get that fibrinogen a little bit up.
So speaking of the fibrinogen, when we're assessing effectiveness, we want to look at that fibrinogen level to make sure that it's trending upward.
Yeah. So oftentimes, and again, I think the textbooks or literature and clinical experience varies a lot with this one, but I like to aim for greater than 150. Some will just say, oh, just get it above 100. If you're below 100, get it above 100. I like to aim for at least above 150, maybe 100 to 150, but I like to get it a little bit higher. And the reason why is when I replace that fibrinogen, I'm doing it to a point where I can hopefully help to aid in what fibrinogen does. It gets converted into fibrin, and fibrin helps to stabilize the platelet plug and the clot itself. And so that's when I would give this drug, is I would actually give fibrinogen via cryoprecipitate, keep an eye on their fibrinogen level. If it was less than 100, I'm going to try and push it close to above 150. Once I've reached above 150, I'm kind of happy with that, and I would be okay, and I don't need to give any more cryoprecipitate.
Hypothetically, again, running just a random scenario here, let's say that our patient had von Willebrand disease. Would this be a potential treatment? Would cryoprecipitate be appropriate for this patient?
It could be. I'd say in emergency scenarios, or where like the concentrated factor. So if you think about it, cryoprecipitate contains von Willebrand factor, factor 8, factor 13, and then fibrinogen. Mm-hmm. So this is really great in fibrinogen deficiencies or hypofibrinogenemia. Where it's okay as a secondary line medication is in von Willebrand's disease or hemophilia A. So usually for these, we have concentrated factors. So I actually have a concentrated von Willebrand factor drug that I could give. Or if a hemophilia A patient, I could give a factor 8 concentrate. But if a patient is at an institution that doesn't have it, or it's an emergency, they're bleeding and you need to replace those factors, then I would give something like this, but not all the time. I'd say it's more of a second line, or a drug that you use when other ones for that condition is not available.
All right. Well, that was case 5. We're moving right along. Let's do case 6.
Let's do it.
Okay. We have a 50-year-old female presents with acute shortness of breath and hypoxemia shortly after a transfusion. The patient received a unit of packed red blood cells, for anemia and developed sudden dyspnea and low oxygen saturation within 6 hours of the transfusion. She denies chest pain but describes feeling tight in her chest. For her exam, we have vitals 98/60, heart rate is 105, respiration is 26, temp is 37 Celsius. For her respiratory exam, we notice bilateral crackles at the lung bases. For our lab findings, we do a chest x-ray. We get back and we see bilateral pulmonary infiltrates. So Zach, based on this patient, what type of transfusion reaction do you suspect, especially with that chest x-ray finding?
So this is a good one. So this is why we are careful with giving blood products. If a patient gets a transfusion and all of a sudden develops these symptoms, I'm worried about something called TRALI, which is transfusion-associated acute lung injury. This is kind of really associated with it. So what happens is it's kind of weird. So the donor product has white blood cells on it, and they have these HLA kind of like proteins on them. Sometimes what can happen is when you transfuse this, you can give these HLA kind of like antibodies that can react with our neutrophils. And when it reacts with the neutrophils, they tend to, for some reason, aggregate to the lungs. And they release lots of inflammatory mediators and reactive oxygen species that causes destruction of the respiratory epithelial tissue and the respiratory capillary tissue, that pulmonary capillary tissue. And if it gets damaged, fluid leaks out of the pulmonary capillaries into the alveoli, and they get filled with fluid. And then it can actually cause the alveoli to get so filled up where it actually impairs, or they get no gas exchange. You can get a shunt process.
Wow.
So this can literally look like ARDS or ARDS, acute respiratory distress syndrome. So this right here, within 6 hours of a transfusion, developing hypoxemia, bilateral pulmonary infiltrates, and no underlying history of CHF or underlying CKD or anything like that would cause more of a volume overload like appearance, or I would make me think this is a non-cardiogenic type of pulmonary edema, highly associated with TRALI. And then on top of that, hypotension. And that's because there's so much inflammation, the systemic mediators of inflammatory mediators get into the bloodstream, the systemic circulation, and vasodilate the circulation, and then fluid leaks out and you end up with a hypovolemia causing hypotension. So hypotension, respiratory distress, pulmonary edema in both lung fields after a transfusion without any history of like fluid retention disease like CHF, highly suspicious of TRALI.
All right, so she's got it. What do you do about treating TRALI?
Biggest thing here is to stop the transfusion. So you got to stop the transfusion.
That might have been obvious.
Yeah. And then for this one, oftentimes you just need to support the respiratory system. So it's oftentimes just supportive care. So stop the transfusion. Once you stop the transfusion, the next thing I would do is I would put them maybe on some type of respiratory support. I would try, let's see, how were they? Feeling tight in the chest. So from there, I would just start off by putting them on nasal cannula. If that's not meeting an oxygen need, then I would bump it up. Maybe go to high flow nasal cannula. If that's not working, maybe go to BiPAP. And if they fail that, maybe then I would need to go to something like potentially intubation. So I would support them respiratory wise and give them some time. Hopefully this will improve over time, but it can potentially progress significant enough where a patient can develop severe hypoxemia and they need to be intubated. But that's what I would do, is just supportive care, stop the transfusion, support their oxygenation, depending upon the need that they have, because they're from nasal cannula, could go up to a non-rebreather, could go up to BiPAP or high flow nasal cannula, and if needed, intubation.
And because you said this is really not volume related, diuretics would do nothing.
No, it might actually worsen it, kill them. Yeah.
Okay, then.
Yeah.
Please avoid that.
Yeah, because if the patient's already hypotensive and they're already kind of volume depleted because they're leaking it out, and you give them diuretics, you could drop their blood volume even more and make them more hypotensive.
Okay. How does one tell the difference between TRALI and TACO? Please tell me what TACO means. And how does their treatment differ?
So TACO is transfusion-associated circulatory overload. It's basically volume overload, like similar, like remember when we talked about IV fluids, if a patient gets like 10 liters of IV fluids, like, oh, let's just hook them up and get them resuscitated, and they blow up like a balloon.
Yeah.
It's the same thing. You're just giving them a lot of blood product, and you're giving it either way too much of it or giving a lot of it too fast.
Okay.
And so the difference between these two is that TRALI is like, it's non-cardiogenic. It's not due to an underlying heart failure. It's not due to volume overload. It's due to an immune reaction that's occurring.
Okay.
TACO is that you're giving too much volume. And by giving that volume, you overload their circulation. I would say that with this patient for taco, I would see hypertension from hypervolemia, right? I would see pulmonary edema. So they would have some respiratory distress. That's why it can kind of look like you'd see bilateral pulmonary edema on these patients. And you'd be like, oh, that's trolley. Not necessarily. If I see a patient with trolley, I'm going to kind of a more likely look for an underlying history that where they have no CHF, no CKD, no kind of condition that makes them super high risk for fluid overload. The other thing is that with taco, you're looking at a patient at their history. They've gotten frequent transfusions, large volume, or they've gotten it way too quickly. They ran the transfusion super quick.
Okay.
In those scenarios, I would expect a patient to also have features of hypertension, pulmonary edema, and I would even expect like some of the right side pressures to be a little bit higher. So they may have some jugular venous distension, some peripheral kind of pulmonary pedal edema. And so that might make me a little bit more concerned for taco, especially if the patient has an underlying history of CHF or CKD or something that makes them more likely to be fluid overloaded.
And then taco, you would treat with diuretics.
Yeah, hit them with the diuretics.
Okay.
Because you're trying to get rid of that excess volume. Whereas in trolley, they were probably getting a little bit more leaky in their capillaries, so they may be a little bit more hypovolemic. For this patient, they're super overloaded. Hit them with heavy doses of Lasix and get some of that fluid off. Hypertension should improve. The pulmonary edema should improve. Their JVD should go down. Their pedal edema should improve. And then they should kind of get better on their own. You may have to support their respiratory system a little bit while they're a little bit pulmonary edema. So they may require a little bit of oxygen, maybe nasal cannula if that doesn't work. Maybe non-rebreather if that doesn't work. High flow versus BiPAP. And if that doesn't work, you may have to intubate them for a little bit. But oftentimes, pretty good diuretic should get that fluid off and they should improve.
Let's say we have another patient, different scenario here, but let's say this other patient has increased LDH, low haptoglobin, AKI, and hypotension after a recent transfusion. What would you be most concerned for?
So this is a good one. So this is kind of goes back to that patient that we had in the beginning where we said if they got a transfusion and they had a fever afterwards, right? When we said with febrile, non-hemolytic, or
Yep.
it was acute hemolytic. This one's acute hemolytic for sure. Because if you have a patient that gets a fever, increased LDH, low haptoglobin, and AKI probably because they dumped hemoglobin into their urine and it kind of chalked up the proximal tubular cells, and hypotension because that massive inflammation is probably causing a little bit of systemic capillary leakage and vasodilation. That's super suggestive of an acute hemolytic reaction. So for me, I would definitely be concerned of that. Probably maybe they didn't get the correct type in crossing. So this sometimes is a clerical error. So usually when we give blood, we try to give like O negative if it's an emergency situation because it's the universal donor. But if you have time and you're likely going to need blood, you'll send in a type in screen or a type in cross. Usually a type in screen is you're doing that if you possibly need blood. Type in cross is I definitely need blood. So usually in that scenario, there was a mess up in a clerical scenario here where they gave blood that wasn't compatible with your patient, and they developed an immune reaction against that blood, and they started hemolyzing the red blood cells. And so in those scenarios, that can be pretty detrimental. You got to stop the transfusion, try to keep their blood pressure a little bit more normal, maybe give them some fluids, and then hopefully that over time, it'll start to improve and they'll stop hemolyzing.
And something like that is probably pretty rare, but it's still a possibility.
Yeah, it is rare, but it is a possibility.
All right, well then let's move on to our final case here. We have case 7. We have a 30-year-old male presents after a motor vehicle collision with severe bleeding. The HPI, the patient was involved in a high-speed crash and arrived at the ED, hypotensive and tachycardic with active bleeding from multiple sites. For his exam, the blood pressure is 80/50, heart rate is 130, respiration is 28, and his temp is 35.5 Celsius. His abdomen is distended and tender. Lab findings. We get some labs back and we see his hemoglobin is 5, a platelet count of 70,000, and a PT-INR of 3. So this is going to be a massive transfusion protocol, MTP.
Yep.
Because there's just crazy amounts of bleeding.
Yeah, in this scenario, when a patient is hemodynamically unstable, there's evidence of exsanguination. If you take the time and say, I'm going to put in a type and cross, we'll get blood no.
Like this dude's bleeding out in your table.
Yeah, so if you have to honestly get to the point where you're really trying to push blood into this patient pretty quickly, and that's when I would say, okay, I need to grab a Belmont. And the Belmonts are usually these little machines that help to rapidly infuse products into the patient. So for me, I would go ahead and say, yeah, let's activate the MTP. So let's get good access. Usually RIC lines or trialysis catheters would be really good. But if you have good 18 gauge IVs, that would also be, as long as they're large bore and you can push product into the patient, get good access and start smashing blood products into them. Usually what I like to do is give a 1:1:1 ratio.
Yep.
So one of packed red cells, one of FFP, and then one of platelets every round. So let's say the first one, I obtain access, maybe I do a trialysis catheter, a RIC line, maybe I have a central line, whatever it is, I have 18 gauge, two 18 gauge IVs, I get my access, I'm going to connect it to my Belmont and run those things and smash product in. For one round, I'm going to run 1 unit of platelets, 1 unit of packed red cells, and 1 unit of FFP. After that, I'm going to look at their blood pressure, look at their overall kind of like hemodynamics and see, are they better or do they need more? Oh, they need more? All right, let's run another round. Let's do another round of 1 unit of packed red cells, 1 unit of platelets, and 1 unit of FFP. After we smash that in really quickly, guess what we're going to do? We're going to go back, look at the vitals. While we're doing this, we're really trying to figure out what's the underlying source. Can we get some source control during this whole process?
Sure.
If the hemodynamics are still not there, keep doing it. So you keep doing that until you get hemodynamics that are a little bit more stable and you can get the patient stable enough to get to an OR where you can get source control. Be careful. I've shot myself in the foot many times when I have activated MTPs and I've gave these patients massive amounts of blood products. We're running pressors, we're running fluids, we're running a bunch of different things, and we're trying to get their blood pressure up. And sometimes it may feel more comfortable for a patient to have a blood pressure where it's a little bit higher and then it is to be a little bit lower.
Okay.
But I actually would prefer to have permissive hypotension. So I don't want to push that blood pressure up too high. So in other words, if I have a patient who has a MAP of 55 or a systolic of like 100, I'm okay with that.
Okay.
I would rather have that because if I push the pressure up a little bit too high, I can theoretically pop the clot and propagate further bleeding. So whenever you're activating a massive transfusion protocol, just be very careful. Give them these products in the 1:1 ratio. Keep an eye, have good access points. Do it until you get improvement in hemodynamics or until you can get them stable enough to get to the OR for source control, but allow for permissive hypotension. Don't push the pressure up too high because you could propagate further bleeding and reopen up whatever platelet plug that you formed. So that's really, really important, I think, in this scenario.
Okay. And for some of you listening out there, maybe you're currently practicing, this is also called a code crimson in some institutions. So just kind of food for thought.
Yeah.
So anyway, we're dealing with an MTP or a code crimson. What are some of the complications that could arise during this?
So that's really important. So when I've been in MTPs and we're pushing all these products in, a lot of the times we'll have team members who are trying to order labs. All right, where's their hemoglobin at? Where's their PTINR? Where's their fibrinogen? All these things. But if you're pushing in product so fast and you're getting a lab at that same time, those labs aren't going to be accurate.
Okay.
And so it's not, I think, as effective at certain times to be ordering multiple labs. I think you can get some of them. And so what I like to do is I like to be a little bit more empirical in my process. But let's say that I'm activating an MTP, I'm 6-7 units of the 1:1 ratio deep in this process. Still kind of struggling to get their pressure up. Still trying to get them to be a little bit more hemodynamically stable. I will try to run these things if you can have them. A lot of the EDs and some ICs will have iStats. I'll check calcium levels, I'll check potassium levels. The reason why is when you give lots of blood product, especially packed red cells, it contains citrate in it. So we talked about this in hypocalcemia. Citrate binds with the calcium and then it decreases the amount of free calcium in the blood. Hypocalcemia can be super problematic. The reason why is calcium is actually needed in order for us to clot.
Yeah.
So if I have a patient who has hypocalcemia and I keep giving them blood product, I can deplete it enough where they actually stop clotting. And a patient who's bleeding, that could be detrimental. So iStats are really good to get calcium levels, especially I like iCals. Those are a little bit more accurate in those scenarios. So I would try my best to order iCals, but my way of doing this is I give 1:1 ratio. So every round, I'll give them an amp of calcium.
Okay.
So that's one thing I like to do, and just keep making sure that I replete the calcium. I'd rather them be hypercalcemic in this kind of scenario than I would them be hypocalcemic. But I will get iStats and order iCals if I can. I just have to be careful because I don't know how accurate they'll be when I'm pushing in products so fast.
Sure. Yeah.
Next thing is hypothermia. This can happen because of blood loss. This can happen because of being in a cold environment. This could be due to the reason why the patient comes in. A lot of things happen. There's like whenever you have a patient who's let's say, as we say, circling the drain, we call it the triad of death, which is whenever they're acidotic, coagulopathic, and hypothermic.
Okay.
So hypothermia definitely can really cause worsening coagulopathy. And so we want to actually keep these patients warm. the best we can. So warming blankets, and then also usually when we're running a lot of these products in, we try to run it through a fluid warmer to make sure that
that's pretty cool.
Yeah, so a lot of these products that are coming in, hopefully they're being warmed if we can. There's people all over these rooms when this is happening, so it is kind of tough, but you do your best to try to make sure that the fluid that you're running into the patient is warm, because you want to try to keep their temperature normal, because if not, you can cause hypothermia and then precipitate worsening coagulopathy and worsening bleeding. The last thing is when you give this massive amount of blood products, every red blood cell is filled with 97% of it is like inside of the cell, potassium is rich in these cells. And so if you give tons and tons of blood products, some of that potassium can actually leak out of those red cells. And if you're giving tons and tons of units, you run the risk of hyperkalemia. So just be careful. I keep an eye on their ECG. Look for any evidence of peak T waves. Look for any evidence of a widening QRS, a dropping of the P wave or the prolonging of the PR interval, etc. And just maybe have some calcium on hand, because that's what we would be giving to this patient as well. Hopefully giving them some calcium gluconate will stabilize those cardiac membranes. So that's the kind of way that I like to look about these as I'm going through these kind of patients.
So you're monitoring the potassium, monitoring calcium. What about is there any indication for cryoprecipitate in the 1:1:1 ratio?
I'd love to. There's a guy out there. He's an intensivist. I forget his name, but it's for the Internet Book of Critical Care podcast. He's really amazing out there, and he says he wants to kind of dub it called the 1:1:1:1 ratio.
Add an extra one now.
Yeah.
Right?
So in massive transfusions, a lot of patients do have depletions in fibrinogen. So they can develop hypofibrinogenemia. I think if you're running a massive transfusion and you get a chance to check a fibrinogen to look to see if it's less than 100, and it is, give them cryo. Otherwise, probably just continue to run your actual normal 1:1:1 ratio. But yeah, I don't think it would be a bad thing. If a patient's bleeding whole blood, give them whole blood back. Mm-hmm. You're giving them packed red cells, you're giving them platelets, and you're giving them FFP. FFP does contain fibrinogen, but if you need more, just check and see if you need that. So check the fibrinogen level. If it is really low, give them cryo. That would be my indication for that.
All right. Let's say this patient has received approximately 12 units of the 1:1:1 ratio.
Oh my gosh. Yeah.
Maybe it's the 1:1:1:1.
To 1 ratio. Yeah.
What complications are they at risk for now that they present with pulmonary edema, JVD, and hypertension?
So this seems like taco.
We're back to taco.
It seems like taco. Yeah. So when you get lots of units, you're giving volume. Think about it. FFP is about 200 to 300 mLs. And so if you're getting 12 units of that, that's a lot.
Yeah.
Packed red cells is about 300 mLs a bag. And then platelets aren't a ton. It just depends upon the way the bag comes. So some MTP coolers will come with a really big bag. It's like a pooled apheresis bag, and it's like 6 single donor platelet bags in one. So you may, like, for example, let's say that you get a cooler and it has 6 packs of red blood cells, 6 packs of FFP, and one gargantuous bag of platelets. That could be a single, that could be a pooled bag of apheretic platelets, which is about 6 single donor platelets, which is that 1:1:1 ratio. So if you're giving all of these, you're giving large amounts of volume. And if a patient is getting this and they start developing pulmonary edema, JVD, hypertension, I'm suspecting they got taco, and I'm going to go ahead and diurese them.
I was going to say, now we have the 1:1:1:1 with diuretics.
Yeah, exactly.
This patient is getting so much medication.
Yeah, and I think that's the important thing, is that whenever you're running an MTP, it is great to try and do your best to check these labs while you're running it, but I wouldn't bear a lot of weight into them. That's why there's new tests out there, as I've said before. The thromboelastography, the TEGs, might be a little bit better to run during these kind of traumatic scenarios as compared to getting your classic CVC and platelets and et cetera.
That's all I got for you, man.
Yeah, this was a beast, man, but it was kind of cool. I really enjoyed doing this one.
It was really fun.
Yeah, because you kind of, as a provider, you naturally kind of push these products out to patients sometimes. I'm guilty of it. And I don't think about all the potential weight that comes with this and the potential complications that can arise. But I think knowing whenever you're giving these things, it's just like fluids, it's just like a drug. You need to treat it very seriously and know about these and know why you give them, what you're really looking for to make sure that it's actually effective, and how much do I give? When do I stop? And what are the potential things that I should be watching out for?
Yeah, no, that's it was awesome. Very interesting. We did it in one take.
Yeah, that was cool.
So that's cool.
That was cool.
But that's all we have on blood transfusion.
Yeah, so seriously, thank you all so much for listening to this podcast on blood transfusions. I really hope that you learned a lot about the different types of blood products, why we use them, what do we monitor for, and what are potential complications that can arise if we don't think about this properly, and then how can we mitigate that. If you did like it, Please continue to support us. Hit the like button, comment down in the comment section, subscribe. And on top of that, be a winner and go check out our website. On our website, we got tons and tons of notes, illustrations, quiz questions, so many things that I think will really help you and to just crash and destroy all your courses. So please go check that out. But without further ado, I love you guys. I thank you guys. And as always, until next time.